Our first speaker is AeRang Kim from Children's National. She's going to be talking about some overview of Ewing sarcoma and NF1 cancers. AeRang?
Oh, barely see. I'm so short. Okay. Well, thank you so much for giving me the opportunity to speak today. And I'll be discussing the clinical overview of Ewing sarcomas and NF1-associated cancers. So I know today's focus of the symposium is new drugs for new cures. And I really wanted to emphasize why I think this is so important, and primarily, particularly important for pediatric sarcomas. Pediatric sarcomas make up about 15% of all pediatric cancers, which is much higher than the 1% of sarcomas that are made up in the adult population. But yet they represent about 40% of pediatric patients on phase 1 trials. And although in pediatrics we've had the luxury of significant improvements in survival throughout the years, this survival has not been equal amongst all histologies. And the outcomes for patients with metastatic, recurrent, or refractory sarcomas is dismal. And among those that are cured, there are still significant late toxicities that affect the entire system, including cardiac toxicities, endocrine system, fertilities, and musculoskeletal system. So going with that, I'll be talking about Ewing sarcomas and then NF1-associated cancers, and talking about how we can apply new drugs to those cancers and why it's so critical. So Ewing sarcoma is the second most common bone tumor in children. There's about 200 new cases a year, and it's predominantly in white adolescent males. They typically present with pain and swelling at the site of the tumor, and sometimes can have systemic symptoms such as fever, weight loss, and some protracted symptoms. And the most common sites are located in any bone or also in soft tissue. And this picture is a large pelvic Ewing sarcoma here. There are prognostic factors associated with Ewing sarcomas, the most important being overt metastatic features, which is a poor prognosis and occurs in about 25% of patients at diagnosis. Larger tumors are unfavorable, as well as tumor site, with the distals being more favorable than the axials, such as the pelvic tumors. And age is also a prognostic factor, with older children having worse prognoses. Ewing sarcoma is in a class of these undifferentiated small round blue cell tumors, so it's important to exclude them from other small round blue cell tumors such as lymphoma or neuroblastoma or rhabdomyosarcomas. And Ewing sarcomas also are typically CD99 positive on an immunohistochemical stain. But what really makes Ewing sarcoma interesting is that they all possess this specific translocation of the EWS on chromosome 22 with FLI1 on chromosome 11. And this translocation is seen in the majority of Ewing sarcomas. And really, this transcription drives the malignant phenotype. And in preclinical models, silencing EWS5 reverses the malignant phenotype. So really important in thinking about how we can attack this for drug development. The treatment is very multidisciplinary, and I can't stress this enough, how important it is that this is really a team approach to treating Ewing sarcoma. So you need your medical oncologist, your radiation oncologist, your surgeons, the physical therapists, and of course the psychosocial support. Treatment is typically local and systemic, and the current trend does favor surgery when feasible, and that's surgery with complete resection with wide negative margins. And if surgery is incomplete, then oftentimes adjuvant radiation is used, and if surgery is not feasible, then definitive local control with radiation is used. All patients do receive systemic chemotherapy, and there are many active agents in Ewing sarcoma. And in a trial over 15 years ago, looking at the addition of ifosfamide among a backbone of vincristine, actinomycin, doxorubicin, and cyclophosphamide, demonstrated a significant improvement by adding these drugs in local Ewing sarcoma. And that really brought the backbone of the standard therapy in North America being vincristine, doxorubicin, cyclophosphamide alternating with ifosfamide. But as you can see, this portion, which is the metastatic patients with Ewing sarcomas, have not seen any benefit and still do very dismally. More recently, compressing the cycles with VDCIE for localized tumors demonstrated some improvement improvement in survival, and now is really the current standard of therapy for Ewing sarcoma in North America. So what do we do about this? What do we do about these patients down here? What do we do about those patients that even though this is here, it is not here, which is where we need it to be? Now remember I mentioned that Ewing sarcoma has a specific translocation that really drives this target. So the thought is, well, why aren't we attacking this target? So the challenge of attacking this target is that this is a transcription factor, and the active site of most transcription factors lacks a classic druggable domain. There are multiple protein-protein interactions, which makes attacking the EWS-FLI1 difficult. But luckily, many, and including many in this room, have accepted this challenge. And I know that Dr. Tereski will be talking later on about his drug and his really interesting development of this agent. And others have also tried to target this approach, the Lesnick group with LSD1 inhibitors, and the Grohar group, who gave a wonderful talk at ASCO looking at trabectedin and the newer class of trabectedin for targeting this agent. So now I'm going to switch gears and talk a little bit about the overview of NF1 and their associated tumors. NF1, which is neurofibromatosis type 1, is an autosomal dominant disorder that's really considered a tumor predisposition syndrome. And it can produce tumors such as benign plexiform neurofibromas here that occur oftentimes in young children, can grow quite large, and have associated pain, functional loss, and deformity, and also loss of NF1. And in some patients, these can progress into what we think are an intermediary called atypical neurofibromas, where we know there are further genetic changes, and then in some patients transform into a malignancy called malignant peripheral nerve sheath tumors, where further genetic changes occur. And these are really aggressive sarcomas, and I'm going to be concentrating the remainder of the talk on these sarcomas. So MPNs TS are aggressive soft tissue sarcomas, and they occur in about 4% of all soft tissue sarcomas. But interestingly, in 50% of all MPNs TS occur in patients with NF1. They often develop in pre-existing plexiform neurofibromas, and complete surgery is required for cure. There is no known effective medical therapy, and survival is dismal in patients with refractory or metastatic disease. The clinical signs for malignant degeneration of plexiform neurofibromas is very similar to those that patients with plexiforms experience, so oftentimes there is a delay in diagnosis. And that could be because of the development of the existing and pre-existing plexiform neurofibromas, but also due to sampling errors and the inability to completely resect MPNs TS arising from an already inoperable plexiform neurofibromas. And you can see in these MRI representations, this is a plexiform neurofibroma. They're very bright on T2 imaging, and they have these target lesions that are very consistent with what plexiform neurofibromas look like. And then they transition into some abnormalities within the plexiforms that are very PET-avid and ultimately transform into MPNs TS that are contrast-enhancing, heterogeneous tumors that are lobular shape and just pretty ugly on imaging. And again, complete surgical resection is needed for these cures. And these are wide margins for high-grade MPNs TS, again, which are often not feasible due to tumor location and size. There is some data out there that narrow margins with low-grade MPNs TS or atypical neurofibromas may be sufficient, and this is a really interesting concept. I think that we're learning more and more about atypical neurofibromas and possibly as a preventative measure for development of MPNs TS. We know that radiation and chemotherapy are used in the adjuvant setting, typically radiation for ones that are not fully resectable or very large and high grade. And we know chemotherapy is often used in advanced disease. However, there are no known studies, at least prospectively, where chemotherapy or radiation actually really improves survival in this disease. And this is the leading cause of death in patients with NF1. And so identifying effective treatments in MPNs TS is critical. So back in 2002, there was an international consensus statement on malignant peripheral nerve sheath tumors in NF1, and this was led by Drs. Ferner and Gutman, where they brought together experts across the country to really review the diagnosis and guidelines for MPNs TS and set forth a research agenda. So since 2002, unfortunately, there has not been any known effective treatments for MPNs TS. And so recently, we did get together again, another consensus meeting for MPNs TS, bringing in experts across the country, including some in this room, to discuss what can we do to fix this. Nothing has changed in 15 years. And what we want to say that there is hope. There is hope because even though we haven't defined any effective therapies, there have been many advances in development for finding cures for MPNs TS. So some of these are understanding better the natural history of these plexiform neurofibromas and what potentially can occur in changes. Imaging advances such as defining the role of PET and whole body MRI. Pathology changes and also pathogenesis. We're learning more and more about the genomics of these and the changes that occur when they transform from plexiforms to atypicals to MPNs TS, and how can we use that to further guide our management. There's been a lot in terms of preclinical development and thinking about rational ways to develop agents for this therapy, and also, importantly, there's been development of consortia and clinical trial efforts to really target this rare disease, and we can make a difference by working together. So since 2002, there have been multiple target agents with MPNs TS, and this is because we now understand better the mechanism of MPNs TS development, and there's been an explosion in oncology of targeted agents. Unfortunately, we haven't really found the cure yet, or even any targets that work, but what this does show is that we can do rare trial developments for rare tumors, and they do accrue quickly, and there is an interest because we desperately need to figure out ways to fix this. One of the real advances have been the development of really preclinical models that can lead and guide the development and translate these targets into clinical trials. So since then, there's been developments of these transgenic mice models in MPNs TS, and these really recapitulate the human models. They're very aggressive, and under the microscope, these mice models look very similar histologically to the human tumors. And we've collaborated with the Tchaikovsky Laboratory with their models, and where they've seen combining agents known to affect downstream targets to MPNs TS developments have caused significant tumor regression in their transgenic mice models. And this work from Dr. DeRate and the Tchaikovsky Laboratory led to the direct translation of the SARC-023 trial, which is a consortium effort funded by the DoD, to combine gantenerumab, which is an HSP90 inhibitor, with the mTOR inhibitor sirolimus for patients with MPNs TS. This trial is recently close to accrual, and the data analysis is occurring. The next iteration is looking at combining other ways of other methods to target MPNs TS, and this is looking at mTOR and MEK inhibition, which caused significant regression in the transgenic mice models. And interestingly, they noticed that the glucose transporter, gluc1, was suppressed when only both pathways were inhibited and not when either one was. And this translated to early suppression of FDG PET uptake in a dose-dependent manner in the mice models, and this correlated with decrease in tumor size later on. And you can see in these mice models, they get these FDG PETs, and you can see that they shrink on, and this is way before they see tumor shrinkage. And the thought is that can we use PET as an early biomarker, imaging biomarker for response for MPNs TS. So our next trial, which hopefully will open in the fall, will be looking at this and a direct translation of this preclinical work, looking at selumetinib, which is a MEK inhibitor, in combination with vistusertib, which is a dual mTOR inhibitor for MPNs TS. So in conclusion and future directions for malignant peripheral lymph tumors, we obviously need models to study more things, including transitions from plexiforms to MPNs TS transitions, models for metastases and resistance. And we need to continue to translate these into clinical trials and validate these models, because you may cure tumors in mice, but that's really not the overall goal. We need to cure them in humans. We have to think about other things as well, such as trials for newly diagnosed and resectable patients, and thinking about measures of preventative measures for ANF. We know that these are likely precursors to MPNs TS. How can we prevent MPNs TS from occurring in the first place? And finally, we need novel trial designs that can accelerate therapeutic development. It's been really exciting to be able to translate some of these findings into the clinical realm, but it takes a lot of time, a lot of effort, and in order to get to patients much quicker, we need to think of ways to accelerate the development. Thank you.
We have a few minutes. Any questions?
How are the epigenetic kind of mutations? Just wondering, the kind of newly found like epigenetic mutations like the PRC2 complex, how are those being targeted, or how would you foresee, exploiting those mutations in MPNST?
So that's an interesting question, and I know we're learning more and more about the genomics of MPNs TS and how we can affect change. So I think one of the things that we're looking at is, there are developing imaging guidelines where we're doing whole body imagings from NF patients to look at plexiforms and going forward. And so you can pick up these distinct nodular lesions on these MRIs of the whole body and biopsy them and depict change. So one of the things that I think would be very interesting to do is looking at these and looking at target agents that may affect some of those transitions that we see in these epigenetic modifiers, and seeing if we can do like phase 0 or early drug trials and actually get paired biopsy samples to see how differences work.
Thank you. I have a question. These atypical neurofibromas are a real complicated issue, right? And it's always been a problem. Is there any national, international efforts to study this prospectively? Prophylactically removing these?
So, the German group and the English group, and it's recently going to be published soon. Dr. Wiedemann's lab has been looking at it. And in that group, there's a recent paper where they resect all atypical neurofibromas. And in that group, even with marginal margins, some of them with microscopic margins, they've had patients that have not progressed into MPNST. But we don't know which ones or how that matters, and I think there is definite need for prospective studies of these. But retrospectively, it seems that there may be a difference.
Thank you. Any other questions? All right. Thank you.